For me, the most important aspect is quality and patient outcomes, but also patient experience. Patients choose to come to us for their surgery, so I want them to have the best outcome possible. We're very standardized, so all of our sites are identical. We use the same instruments, consumables, and equipment at all of our sites. And so for me, to add in a drug that's not going to affect my flow is extremely important. So we operate on about 25 patients on a list. And I'm going to tell you a little bit about what we found when we started to use OMIDRIA in our standard practice. We used historical controls. We looked at 5 of our 62 sites and 5 of the same surgeons. 25% of patients were diabetic, and 20% of patients were from the most lowest decile of deprivation. We use a standard care Apricam, cefuroxime for every patient intracamerally. We use Predforte postoperatively, and we use Yelox or Bromfenac twice a day for our NSAID. Comparing to the OMIDRIA group, we had 536 cases, the same surgeons, and we looked at a month's worth of data. The only thing that we actually changed was the OMIDRIA. So we were able to look at the benefits of adding in OMIDRIA. 400 patients were second eye as well. So it was really good to be able to look at that as a control to see what benefit did the OMIDRIA have. Other than that, we kept our flow the same, and it's the same pathway. We found a significant reduction in our CME rate. So all patients are seen at week 4 to 6. They will be examined by an optometrist and have an OCT, and we saw a staggering reduction in CME rate. That rate was greatest when we compared it to the patients who had first eye without OMIDRIA. A number of those patients, 2%, had CME. When they had the OMIDRIA, the CME results reduced to 0%. We found a significant reduction in our corneal edema rate, but I think more importantly as well, we significantly reduced the use of hooks and rings. And we know that the more hooks and rings you use, the more manipulation, the more time it takes. But more importantly, the inflammation that can cause and the inflammatory cascades will actually increase your risk of CME. What was also quite important for myself was not just about the patient outcome, but also the surgeon experience. So 100% of our surgeons were happy with this drug. We eliminated the use of lidocaine, and often we know that when you inject lidocaine, patients feel some discomfort. We had no discomfort whatsoever. And as I mentioned at the beginning, the aim is to have the best patient experience. So comfortable surgery, reduce complications, and happy, stress-free surgeons is also very, very important.
Why do you get better results with OMIDRIA? Well, you're putting ketorolac into the eye, which I think is really important. I want to thank my co-investigators here. The purpose of this study was to find out why. This is the smoking gun. What is the reason? What is the secret sauce behind OMIDRIA that makes OMIDRIA so effective? And what we did was we looked at patients who are having combined cataract surgery and epiretinal membrane peels. These are patients having combined surgery. I would do the cataract surgery, and then one of my colleagues would come in and do a vitrectomy and a membrane peel. And we did this in one setting, and the patients either got a topical ketorolac 0.4% Acular, 0.4% 4 times a day, or they didn't get any preoperative non-steroidal at all, and they got intracameral OMIDRIA at the time of surgery. And the premise of our study was that when we do cataract surgery, especially today with modern cataract techniques, what we know is that with a high bottle or an infusion bottle, which most of the machines have now, you're having forced pressure into the eye, and actually the BSS inside the eye is being forced through the zonules into the vitreous to achieve high vitreous levels as well. That was our theory, and we wanted to prove that theory. So we decided to do the study. I did the cataract, we froze them, we did the vitrectomy, and we measured the amount of ketorolac in the aqueous and in the vitreous. We sent it to an independent lab. The aqueous concentration is basically pure OMIDRIA. So you're getting pure OMIDRIA in the aqueous sample, so you expect that to be very high. That's not a surprise. Much higher than the ketorolac in the beginning case. So you're getting better penetration, you're getting very high levels in the aqueous, completely expected. But what was our theory, which we've shown now in this trial, is that when you look at the vitreous concentration, the amount of vitreous from a topical drop that gets into the vitreous is below the assay sensitivity. So you couldn't even measure ketorolac in the vitreous. And we all know if you're going to prevent CME, where does the ketorolac need to be? Well, it needs to be in the vitreous, it needs to be on the retina. So you didn't get any. But on the other hand, when you looked at the vitreous levels, you had 548 nanograms per ml of ketorolac in the vitreous. So it's getting into the vitreous, and our theory is that once it gets into the vitreous, it stays in the vitreous, so you have a prolonged bathing of the retina in ketorolac. The elevated bottle heights pressurizes the phacoemulsification, and forces fluids between the zonules into the vitreous, and that's why we theorize we're getting much higher levels of ketorolac in the vitreous. And I think that's the secret sauce, and I think this explains exactly why all the studies, and there have been a dozen studies done now that show unequivocally that when you use OMIDRIA, you become a better surgeon, you have less complications, the patients have better results, you have less CME, clearer corneas, and at the end of the day, that's my personal goal as a cataract surgeon, is to make it a good patient experience. And OMIDRIA makes it a good patient experience, and I think now we know why that happens.